What's up, Ninja Nerds? In this video today, we're going to be talking about diabetes insipidus, DI, and SIADH, which is syndrome of inappropriate ADH secretion. Again, this is a part of our clinical medicine section, and if you guys are really enjoying these videos, you're learning a lot from them, they help you, please support us. You can do that by hitting the like button, commenting down in the comment section, and subscribing. Also, I really urge you guys, go down in the description box below. There's a link to our website where you guys can become a member and have access to thousands of notes, thousands of illustrations, thousands of quiz questions, and there's even exam prep courses that we're developing as well. So go check that out. But without further ado, let's talk about DI and SIADH. So these two disorders are really disorders of ADH production, is really what it comes down to. Now you have to remember that ADH is produced from the posterior pituitary, right? There's these neurons that extend from the hypothalamus down to the posterior pituitary, and basically ADH is already synthesized. It's just sitting in the synaptic vesicles waiting to be released. Well, in diabetes insipidus, what happens is ADH production is reduced, significantly reduced, right? And there's two different reasons why there's one reason why it can be reduced. So when we talk about this, we have to remember again, the posterior pituitary is the source of ADH production, right? So one of the reasons why patients may exhibit diabetes insipidus is a problem where the hypothalamus and the pituitary could be dysfunctional. That's usually the reason why. So maybe there's some type of dysfunction in the posterior pituitary or in the hypothalamus. And we'll talk about a little bit of that. But what we call this is we refer to that as central DI. So it's a diabetes insipidus that is central in origin, meaning that in this disease, there is a reduction in ADH production, all right? Now ADH, what it does is it goes down to the kidneys and it acts on these specific receptors here at the collecting duct. These receptors are referred to as the V2 receptors. Another name for ADH is also referred to as vasopressin. So ADH, what it does is it binds onto these receptors here called the vasopressin 2 receptors or the ADH2 receptors. And what it's designed to do is it's designed to help to express these little like proteins on the surface, the luminal surface, called aquaporins. And these aquaporins, whenever ADH is present, they'll get shoved into the actual luminal membrane. And what they'll help to do is they'll help to move water from the actual collecting duct tubules into the bloodstream, right? And so ADH is responsible for stimulating that process. If you have a reduction in ADH production, will you be able to reabsorb that water? No. And so this process is inhibited because you don't have ADH being produced to bind onto the V2 receptors to stimulate water reabsorption. Therefore, water reabsorption is reduced, and then unfortunately, tons of this water get lost into the urine. And so oftentimes these patients have like profound polyuria. Now that's one concept, is that there's something wrong with the hypothalamus or the posterior pituitary. But there's another reason you can have DI. One is called nephrogenic DI. In nephrogenic DI, the problem is ADH production could be normal, but the V2 receptors are having some type of dysfunction. So in this scenario, nephrogenic DI, if your V2 receptors are dysfunctional, even if ADH is present in normal amounts, the V2 receptors won't respond. If they don't respond, it's as if ADH is not even present at all. Therefore, aquaporins won't be plugged in, you won't reabsorb water, and you'll lose a lot of water into the urine. So that's the concept, and we'll go over this a teensy bit more in a second, but remember, DI can have a central component where you're not releasing ADH, or a peripheral nephrogenic component where ADH is produced, but it doesn't bind to the receptor and have the same effect. As a result, you don't reabsorb water and lose water in the urine. Let's talk about these two. So in central DI, the whole concept here is that this posterior pituitary hypothalamus, it's injured in some way, shape, or form. That's what we've come to. And therefore, as a result, there's a reduction in ADH. If there's a reduction in ADH, there's no stimulation of the V2 receptors. So as a result, V2 receptors are going to become less stimulated, so less activation here. As a result, you're not going to plug these aquaporins into the actual luminal membrane, and therefore water reabsorption will be reduced. So less water will be reabsorbed, more water will be lost in the urine. What's the reason for all this destruction of the hypothalamus or the posterior pituitary? A couple different reasons. One is there's a disease, it's called Sheehan syndrome. And in Sheehan syndrome, what happens is the patient undergoes what's called postpartum hemorrhage. So after they've had birth, they maybe lose greater than a liter of blood within 24 hours, or they lose enough blood that they become hypovolemic and hypotensive. So as a result, they lose blood volume. So their blood volume will drop from the blood loss. And if their blood volume drops from the blood loss, so can their blood pressure. So oftentimes what we see as the result of this blood loss is a reduction in blood volume, which leads to hypovolemia, and a reduction in blood pressure. As we reduce blood pressure, and on top of that, you know what else happens? In patients who have postpartum hemorrhage, they throw off a lot of their coagulation factors, and they end up causing clots that consume a bunch of their clotting proteins, and it can lead to DIC. So sometimes they can get a low BP, and they can get what's called DIC. Either way, the combination of these factors, what ends up happening is they throw off the perfusion to the pituitary. And as you throw off the perfusion to the pituitary, it increases the risk of what's called infarction. So as a result, these patients may undergo infarction of their posterior pituitary and hypothalamus and lead to destruction of the actual neurons that release ADH. That's one reason. So Sheehan syndrome, postpartum hemorrhage as a result. The other one is called pituitary apoplexy. So if a patient has what's called pituitary apoplexy, they have a pituitary adenoma that they bled into. So they bled into that tumor bed. What happens is that whenever you bleed into that tumor bed, it ends up leading to compression of the nearby vessels that are supplying the pituitary and the hypothalamus in that vicinity. So as you have more vascular compression, you may squeeze some of the arterial supply to the posterior pituitary and to the hypothalamus. As a result, you get the same kind of concept here, is that you reduce perfusion to the pituitary. And as you reduce perfusion to the pituitary, this may trigger death of the tissue cells and lead to infarction. And as you stimulate infarction, the cells die, they lose the capability of producing ADH. The next one is called a pituitary adenoma, but it has to be really big that it's causing compression. So it's called a pituitary macroadenoma. How do we define that? It has to be at least greater than 10 millimeters in size. With this large size, it compresses the anterior pituitary, and it may even compress the posterior pituitary. So if you cause increased compression of the actual tissue, you may cause destruction of the tissue. So increased compression may lead to loss of function. And so this increased compression may lead to loss of function. As a result, a reduction in ADH production. Last one's actually probably very common, believe it or not. I see it a lot in the neuro ICU. Patients who have a neurosurgical procedure where you cut those little suckers off. So if a patient undergoes what's called a transsphenoidal resection. In other words, they have a procedure at or near the pituitary and they end up removing the posterior pituitary. Think about it, dude. If you remove the posterior pituitary, you remove the literal source of ADH production. And so these are commonly the triggers of why a patient would have a reduced production of ADH. All right, beautiful. Now we go to the next component, nephrogenic DI. In nephrogenic DI, the pituitary and the hypothalamus, these puppies are good. They're working out well. So these are normal. So let's actually put that these are okay. If these are okay, then what they'll do is they'll be able to produce, we're just going to put here a normal amount of ADH. There's no abnormality with an ADH production here. So ADH production is normal, right? But here's where the problem is. The problem exists here. There's dysfunction in these V2 receptors. They're just not working. So ADH is being produced, which means that it's circulating through the bloodstream and it's trying to come here and act on these V2 receptors. But it doesn't exert any effect on the V2 receptors. Because of that, water will not be reabsorbed. And if water is not going to be reabsorbed, we will lose that water. There'll be less water reabsorption and more water loss in the urine. The question arises, what's causing this V2 receptor dysfunction? There's three common causes. One is it could be due to lithium. Now, whenever you see this in the vignette, what I want you to assume is, okay, do they have anything written in the vignette or anything in their history that suggests why they would be on lithium, such as a mood disorder, such as bipolar disorder? If you see that, you really want to be thinking that's causing the V2 receptor dysfunction. The other one is hypokalemia, but it has to be really profound hypokalemia. And so when I think hypokalemia, I'm really looking for GI losses or renal losses. So I want you to suspect, has there been any GI losses or renal losses? What do I mean? Have they been vomiting? Have they had lots of diarrhea? Or on top of that, have they had any diuretic overuse? The other thing is with hypokalemia comes ECG changes. So you really want to assess for any ECG changes. Do you guys remember what it kind of looks like in these patients? Starts off with T wave inversions, goes into U waves, and then they can cause a prolonged QT interval, which can increase the risk of torsades. So assess for ECG changes and assess for any losses where you could lose the potassium. The last one is usually hypercalcemia. This has to be really, really high. With hypercalcemia, you really want to think about this. You want to think about that acronym, the bones, stones, groans, thrones, psychiatric overtones. I'm not going to write all that, but I really want you guys to think about that. So have they had a history of lots of kidney stones, osteoporosis, bone fractures, pathological fractures usually, pancreatitis, psychiatric disorders, arrhythmias such as changes in their QT interval. Remember, it's always inverse, so low QT intervals. The other thing is look for a history. Do they have any history of high parathyroid hormone? So do they have any history of hyperparathyroidism? Or do they have any history of malignancy? Because these are usually the only two. And when I mean malignancy, I mean things like multiple myeloma, lymphomas, as well as, sometimes you can see this particularly in other patients like squamous cell carcinomas of the head and the neck. But usually I really want to think, do they have a history of malignancy or hyperparathyroidism? This is usually the trigger for V2 receptor dysfunction. Now that we have an idea of this, it's the same kind of concept. You're not reabsorbing water, It's just this one, reduction in ADH, this one, normal ADH, but V2 receptor dysfunction. Okay, beautiful. So we got a problem when we don't release ADH. You end up causing a lot of water to be lost in the urine. What about when you produce too much ADH? So now we get into this condition called syndrome of inappropriate ADH secretion, or SIADH. Two reasons why this would happen. One is the posterior pituitary has an increased release of ADH. There's a lot of different reasons why, but there's a pituitary problem. So something is wrong with the pituitary where it's becoming hyperactive and it's increasing the production of ADH. If that is the case, so there is some type of increased pituitary ADH release. Something is going on where there is lots of increased pituitary ADH release. And we'll talk about some reasons of why that would happen. This is by far going to be one of the more common ones. The other one is that you have some type of tumor or neuroendocrine cells that have usually formed. It's usually because of a tumor where there is an ectopic ADH production. So we call this ectopic ADH production. Now, what do I mean by ectopic? I mean that this is not a normal site of ADH production. It should be produced by the pituitary. And if the pituitary is producing too much of it, we'll figure out what those things are. But if it's not from the pituitary and it's from a tumor, some other site that's making ADH that it's not supposed to be, then I want to go looking for that. And we'll talk about what those things are. But either way, in both of these scenarios, ADH is being released in too high of an amount. When ADH is released in high amounts, goes here, really stimulates these V2 receptors. Now, the V2 receptors, when hyperactivated, will then increase the expression of aquaporin subunits. If I express a lot of these little aquaporin subunits in here, any water that is going to be present in the collecting duct will then move very beautifully from the actual lumen and into the bloodstream. And so this process will be very heavily stimulated. As a result, I'll increase my water reabsorption. And then as a result, there'll be very little amounts of water that will be present in the urine. This is the big difference between these two disorders, DI and SIADH. Little water in the urine, lots of water in the urine. Lots of water in the bloodstream, very little water being returned to the bloodstream. The question now comes, what's triggering the increased pituitary ADH release, and what is this thing that's causing ADH production that's not from the pituitary? Well, the increased pituitary ADH release is going to be by far the most common cause of SIADH. What happens here, it's not truly well understood, but the concept here is that in situations where there is really low oxygen levels, so some type of process that's leading to hypoxia. Hypoxia can be a very profound stimulus for ADH production. You're like, really? That's weird. It can be. This could be due to a stress response. This could be due to a lot of different things. Like whenever you're hypoxic, sometimes patients can have a lot of like profound organ failure and your body tries to generate ways of increasing your blood pressure and perfusion. ADH is one of those. And so that may be more of like a stress response effect. But either way, scenarios where there's really low oxygen could also be a trigger. Well, what are things that could cause disease of the lungs? Well, a couple different pulmonary diseases that I want you guys to be able to remember is the following. One is, do they have something like pneumonia? Do they have something like COPD? Or are they intubated? Because patients who are on mechanical ventilators can commonly get this. So you want to think, do they have COPD? Do they have pneumonia? Do they have ARDS? Or are they intubated? So anybody who's receiving like some type of positive pressure ventilation in some form can also have this type of process. And this could be a trigger for, hey, let's tell that pituitary to go ahead and start pumping out more of the ADH. Another one is it could be intracranial disease. So a lot of intracranial diseases, this is usually something that's either at or very close to the hypothalamus and the pituitary area. So if you have some type of brain pathology in that vicinity, for example, if a patient has something like a stroke, or they have something like a bleed, or they have even like sometimes traumatic brain injuries that are at or near the hypothalamic area, this could definitely be a trigger. So it's usually injury that is near the hypothalamus. What are a couple of these that I want you guys to think about? Well, a couple of these, again, I kind of mentioned it, stroke, bleed, traumatic brain injury would be the big one. So some type of stroke, maybe an ICH or a subarachnoid hemorrhage, or lastly, a traumatic brain injury. These are some particular pathologies that I would really want you guys to think about. And again, profound stimulator for ADH production. The last one is drugs. There's a bunch of different drugs that may have the capabilities of increasing the activity of ADH production. A couple of those that I think are worth remembering are three types. One is it's going to be what's called SSRIs, so selective serotonin reuptake inhibitors are a very big trigger. Another one is called carbamazepine. That's a really big one as well. And then tricyclic antidepressants can also be very strong triggers for ADH production. So when a patient has SIADH, you have to ask yourself the question, do they have pulmonary disease, intracranial disease, or are they on particular drugs? Oftentimes, the most common trigger is going to be intracranial disease. So look for a patient who has underlying neurological deficits, altered mental status of some sort. If you can't see that, look for any underlying hypoxia or pulmonary disease. And then lastly, think about drugs, but it should be more of an exclusionary basis. Now, the last thing that I want you guys to think about is, could it be an ectopic site? Usually you want to look for a patient who has an underlying history of something called small cell lung cancer. So in a patient who has what's called small cell lung cancer, they can create this concept where the tumor can kind of transform into this neuroendocrine type of cells. And so what happens is they generate something called a paraneoplastic syndrome. And with this tumor then gains the capacity to be able to produce large amounts of ADH. With that being said, if we have large amounts of ADH, what ends up happening? What do they do to the kidneys? They go to the kidneys and they end up causing increased water reabsorption. So this is the concept that I really want you guys to understand here, is that in a patient who has SIADH, think about intracranial disease, neurodeficits, altered mental status, some type of pathology that's affecting their neuroexam. Then think about pulmonary diseases, pneumonia, COPD, are they intubated, do they have ARDS? Lastly, think about certain drugs. And then if from there you haven't found anything, also consider about ectopic sites, like look for any evidence of lung cancer, look for any cough, weight loss, hemoptysis of some sort that would suggest this is the source. Now that we've really gone into this, let's now talk about what are the problems, what's the issue, what's the complications that can arise when ADH is too low and when ADH is too high. All right, my friends, so we talked a lot about DI, SIADH, we talked about the pathophys, the causes behind them. I think the big question is how will these present? Well, oftentimes it's all related to that water factor, right? So is in DI, what's happening? You're not really reabsorbing water, you're losing a lot of water into the urine, right? So it's the same concept here. And so these patients oftentimes, really, they get rid of so much water that they lose a lot of the water in their bloodstream, that their sodium actually starts becoming a little bit more profound. And so they end up developing hypernatremia. Concept behind this is, again, pretty straightforward. We already talked about this, that in DI, either there is a reduction in ADH, so it's one of the two, right? So there's either a reduction in ADH or there's dysfunction of the ADH receptors. Either way, same concept, central nephrogenic DI. In this scenario, are you going to be reabsorbing water? No. So that's the concept, is that either way, it doesn't really matter in this scenario whether it's nephrogenic or it's central. The pathophysiology endpoint is the same, is that you won't reabsorb water. As a result, there'll be less water inside of the bloodstream. And as a result, if you're not reabsorbing this water, a lot of this water is ending up inside of the urine. Now, when you end up with a ton of water in the urine, it's usually pretty large volumes. And so this large volume of water in the urine ends up leading to pretty substantial urine output. And so whenever the patient is producing like greater than 3 liters of urine in a very short amount of time, generally like a 24-hour period, we start to say that they're kind of moving into what's called the polyuria type of phase. So either they're peeing really frequently or they're peeing out very large volumes. Either way, this is what we see due to the water loss in the urine, all right? The second thing is that whenever you lose a lot of water in the urine, you don't get enough water reabsorption into the bloodstream. So there's decreased water in the bloodstream. As a result, this decreased water leads to an increase in your serum sodium. So now as a result of losing that water, you're going to have an increase in the amount of serum sodium. Now, whenever sodium goes up, we call this hypernatremia. At what point do we diagnose hypernatremia? Well, off the lab values, whenever it's greater than or equal to 145 milliequivalents per liter. Whenever that goes up, what happens is this high amount of sodium can do two things. One is it can make the actual blood really like hypertonic or hyperosmolar, really concentrated. And so we call that an increase in osmolality. So there's an increase in the osmolality, blood super concentrated. The problem with that is that whenever the blood is really hyperosmolar, it really has a profound stimulus on the hypothalamus. And the hypothalamus has these different types of osmoreceptors that are present on it, the subfurnicular organ, right? There's all these different types of things there. But what happens is it stimulates the hypothalamus and particularly really drives up your thirst mechanism. And what do we call that whenever the patient becomes really, really thirsty? It's called polydipsia. And so what happens is, we'll actually write this as a result, whenever you stimulate the hypothalamic thirst center, this triggers them to become super thirsty, which is referred to as polydipsia. So one effect of hypernatremia is that the patient can become profoundly thirsty. Now here's another thing. When a patient's putting out lots of urine, right, and maybe in a scenario where they have an inadequate intake of water, there's something terrible can happen. So let's say that a patient becomes hypernatremic, and what happens is they don't intake enough water. So they become hypernatremic, or actually I would say more specifically with the polyuria factor. So let's say that you lose a lot of this, that you lose a lot of water in the actual urine. If you lose a lot of water in the urine, what happens is less water in the bloodstream. This could lead to a mild hypovolemia. So the patient's blood volume could drop a little bit, right? Now what we do is that this will trigger the patient to become thirsty, they'll drink a lot of water and then replace their blood volume. But oftentimes this can occur whenever there's inadequate hydration. So usually this is a result of inadequate hydration may be the trigger for these patients becoming hypovolemic. Either way, in this hypovolemic state, these patients will exhibit signs of maybe dehydration. And hypovolemia can manifest in a bunch of different ways, right? The blood pressure could be low. They could have dry mucous membranes. They could have a decreased skin turgor. They may have a flat jugular vein, or they may have a flat IVC. Their urine output may be a little bit lower. So that's usually the scenarios that these patients can become dehydrated, particularly if there is inadequate hydration. That's the big factor here. Usually this happens in like older individuals or patients with an altered mental status or delirium who don't have adequate access to water. But either way, in a patient with DI, you really want to watch out for high sodium, polydipsia where they're super thirsty, dehydration, usually an inadequate hydration. So in other words, they don't drink enough because they don't have access to it, they're altered, they're geriatric, some sort of that way, or even intubated in ICU. And lastly, they're producing large volumes of urine, polyuria. SIADH primarily will cause a disease called hyponatremia, which is when the sodium level is less than 135 milliequivalents per liter. What happens in hyponatremia is very straightforward. In this scenario here, ADH is usually produced in way too high of an amount. So there's very profound levels of ADH production. We talked about that, from increased pituitary ADH release, ectopic ADH production. Either way, you're getting hyperactive stimulation of the V2 receptors. So these puppies are just pumping. And what is it doing again? What is it doing? It's ended up increasing the expression of aquaporin subunits on the luminal surface. You're stimulating the selection of those to increase the amount of water that's being reabsorbed into the bloodstream, right? So theoretically, there should be less amount of water that you're actually putting into the urine. In that theory, right? So in this scenario here, there should be less water or decreased volume or decreased amount of water that's lost in the urine because you're banking all the water that's really kind of getting to your kidneys. So usually their urine is profoundly concentrated. But here's the big thing. When you increase the reabsorption of water, what happens is you end up causing a dilution of the amount of sodium. And as a result, the sodium levels will tend to drop. So these patients may have a drop in their sodium levels. That's referred to as hyponatremia. Whenever sodium levels dropped, if they drop profoundly and acutely, they can cause a lot of osmotic shifts. And so this is usually what happens is that they can trigger these osmotic shifts. One of the effects here from the osmotic shifts is the terrifying one. Is that here's a normal sized brain, right? Normal sized brain. And then what happens is we're going to kind of convert this normal sized brain into a very large edematous brain. So what happens is with these osmotic shifts is patients often will develop something called cerebral edema. It's a pretty straightforward concept. So in the actual brain tissue, right, what happens is there's a normal movement of water, which is usually going to be moving in and out of the actual neurons of the brain. If the sodium level in the bloodstream is low, maybe the sodium inside of the actual brain cells will be a little bit higher. And what happens is this starts to pull water into these actual brain cells. And when you pull lots of water into these brain cells, it starts causing swelling, which leads to cerebral edema. The problem with cerebral edema is this can present a variable type of ways. In other words, one of the biggest things is that the swelling, it gets big enough. You know, there's what's called the Monroe-Kelly doctrine. It says inside the skull is like a fixed space. So if you have more brain tissue or abnormal amounts of brain tissue, more blood or more CSF, the pressure inside of the actual skull will increase. We call that an increase in the intracranial pressure. And that's oftentimes one of the biggest complications, is that the ICP will go up. As ICP goes up, patients can develop a variable amount of presentations. One is they may present with a very terrible headache. One is they could also have nausea and vomiting. The other one is they could start having frank herniation. Now you're like, what the heck, herniation? That sounds terrible. And so herniation can look a bunch of different ways. Oftentimes they start compressing their brainstem and they start having pupillary changes like anisocoria and a non-reactive pupil. and their level of mental status starts to decline. They become lethargic or stuporous or obtunded or comatose. And so I think one of the biggest things here is that with acute hyponatremia, you can cause massive osmotic shifts, which lead to cerebral edema, increased ICP, and the scariest thing is herniation, which can lead to brain death. So that's a very terrifying thing, and you don't want that to happen. Another thing that can also happen is whenever you have hyponatremia, this can cause osmotic shifting, but it also may do something to the brain tissue, especially near the cortex. It may start aggravating some of the cortical tissue. And when you aggravate this cortical tissue, it can increase the irritability of the cortex. So it can cause increased cortical irritability. And now, if I irritate the cortex, now this sucker can fire inappropriately. And if it fires inappropriately, it may lead to seizures. And oftentimes these are terrifying, generalized tonic-clonic seizures. And so this is something that I want to watch out for as well, because hyponatremia has been shown to lower the seizure threshold and increase cortical irritability and lead to seizures. So two common presentations that you can see in the worst case scenario of SIADH associated with hyponatremia is seizures and cerebral edema. However, this type of effect here really only occurs when the sodium drops acutely. So if there's an acute drop in sodium, so we would say if there's an acute drop in sodium, or if the sodium dropped to the point of where it's less than 120, but usually it's whenever there's acute drops. So again, we'll say whenever the sodium drops significantly, it can cause osmotic shifting, but it's usually either has to be acute or less than 120. Same thing here, has to be acute or less than 120. Then it can stimulate these profound osmotic shifts, or it can stimulate cortical irritability and lower the seizure threshold. So the things that I want you guys to remember between these two is in DI, there's hypernatremia due to water loss in the urine, polyuria. They will get thirsty. If they drink enough, cool, they won't become dehydrated. But if they have inadequate access to water, or they have delirium that alters their hydration, or they're intubated and they can't get water, they could develop dehydration, hypovolemia, and low blood pressure. And then lastly, they will have very large amounts of urine and they'll have large urine outputs. With SIADH, they can have hyponatremia due to reabsorbing tons of water, diluting their sodium. If the sodium drops acutely or very low, it can lower the seizure threshold, cause seizures, or osmotic shifting that leads to cerebral edema, increase intracranial pressure, and possibly herniation. All right, my friends, now that we've talked about this, let's go into the diagnostics. All right, let's now move into the diagnostic approach of diabetes insipidus. So a patient who has diabetes insipidus, oftentimes they'll come in with polyuria, polydipsia, maybe even in severe cases, dehydration due to not maintaining an adequate water intake, and even hypernatremia is a very common presentation. So if they come in, polyuria, polydipsia, maybe they appear a little bit dehydrated, I got to look for the hypernatremia then. I'll get a BMP. If the BMP shows the sodium is greater than 145, they have hypernatremia. But then I got to ask myself the question, what was one of the big things that Zach said about the ADH? Well, if I don't have ADH, then I don't reabsorb water and I dump a lot of water in my urine, and I don't have a lot of water in my bloodstream. So that would change my osmolalities. So in the urine, I'd have a lot of water, so the urine osmolality should go down. And in my serum, I don't have a lot of water, so my serum osmolality should go up. Oh, it does? Okay, cool. Then this is definitely very suggestive of, DI. But there's another disease that actually can kind of be a little interesting. It's called primary polydipsia or psychogenic polydipsia. The concept behind this is that patients present with severe polyuria. And oftentimes in primary polydipsia, the inciting event is that they're drinking like greater than 12 liters of water per day. So the concept here is if I take away the water that they're drinking, they should stop having excessive polyuria, and therefore their urine osmolality should actually increase. If that happens, they have primary polydipsia because their trigger was excessive water intake, and that shut the ADH off. Okay, well, that takes care of that then. So if the urine osmolality kind of doesn't really change, it tells me that it's a DI problem. It tells me that the ADH is not going to be released no matter what. Or the receptors aren't responding to the ADH. So now I think it's definitely DI. Problem is, I don't know which one it is. I don't know if it's central or if it's nephrogenic. So it's central. I have to remember the problem is that they don't have ADH. With nephrogenic, the problem is that they won't respond to ADH even if it is present. So I'm going to give them a drug, ADH, DDAVP, also known as desmopressin. It's the same thing as ADH. If I give them this, and it's central DI, they should bump their urine osmolality. Why? Because if I give them DDAVP, they're missing it. It should stimulate the receptors. They should reabsorb water. They should have more water in their bloodstream. And as a result, their sodium will kind of come down a little bit and improve. On top of that, they'll have less water in their urine. The urine osmolality will go up, and their polyuria should also subside. That would definitely help me to diagnose central DI. The other scenario would be nephrogenic DI. It shouldn't really do anything. It's the same scenario because the patient's producing ADH appropriately. That's not the issue. So if you give them DDAVP, it won't matter if they have ADH or not. The receptor's not going to respond to it. They're not going to reabsorb water. So therefore, they're still going to have low water in their blood. They're still going to dump a lot of water into their urine, and the urine osmolality is going to remain low. So it won't change. This is super indicative of nephrogenic DI, and I've determined, okay, if it's central, get a look at their pituitary, see what's going on. If it's nephrogenic, check their potassium, check their calcium, and look in their history for any lithium use. All right. What about SIADH? Patient comes in, they don't really have any problems with polyuria. They don't really have any problems with polydipsia. It would really just be hyponatremia, right? So I'd get a patient come in, maybe they were seizing, maybe they had some concerns, and I think that they had some cerebral edema or features of high ICP. So I get a BMP and I check to see what their sodium is. Oh, their sodium's low. All right, it's less than 135. All right. Well, that could be why. Maybe it's SIADH related. So a urine serum osmolality should give me a little bit of an idea here. So if I check it, I got to remember ADH is way too high. If ADH is way too high, it's going to reabsorb a lot of water into the bloodstream. So the serum osmolality in that particular scenario should go down. All right. On top of that, it's actually going to have less water going into the urine. So because of that, the urine osmolality should go up. And that would tell me that ADH is turned on. All right. Okay. That's correct. It's possibly SIADH. All right. The next thing I have to remember, though, is that there is other disorders that can cause hyponatremia that look like this. And so what I got to do is I can look at the volume status, because patients who have hypovolemia can also stimulate ADH production. Patients who are hypervolemic but have a very poor circulating blood volume can also precipitate a ADH process. So how am I supposed to know if it's hypovolemic or hypervolemic or if it's euvolemic? Well, if a patient has euvolemic hyponatremia, meaning that they don't have a lot of edema, they don't look like they're dry mucous membranes or decreased skin turgor, they're not hypertensive, they're not hypotensive, they don't really look like they're that type of patient. They appear to be a normal volume status. That really tells me that there's only 3 potential causes. With euvolemic hyponatremia, you cannot determine that it's SIADH until you have excluded other causes. It is an exclusionary diagnosis. There's 2 other diseases that you have to rule out first. I have to rule out hypothyroidism and early adrenal insufficiency. So I'm going to check my TFTs to make sure that they don't have any hypothyroidism, and check my cortisol to make sure that they don't have any low cortisol levels. If those are normal, then and only then can I say that the patient has SIADH. All right. How do we treat a patient who has diabetes insipidus? Well, you can look at it 2 ways. You got to treat the hypernatremia, but we'll talk about that in the renal lectures. For this patient, you have to treat the cause. And the cause here is that they are either having no ADH production, and in that scenario, you have to give them the ADH. And what was the drug that we gave to do that for the test? DDAVP, desmopressin. So oftentimes it may be required to give these patients if they're super polyuric, and on top of that, they have hypernatremia. Desmopressin may be the drug to help to reduce the polyuria and help to be able to retain some of that water and then bring down their sodium. For nephrogenic DI, it's actually a little odd. What you want to do is you actually kind of want to produce like a little mild hypovolemia, and the mechanism behind this is it actually may help, especially with nephrogenic DI. So drugs that we oftentimes will give to these patients is one of 2. Usually it's a thiazide diuretic. Another one is amiloride, but amiloride is usually the trade for that, or the buzz term for that is lithium-related nephrogenic DI. But oftentimes it's just kind of thiazide diuretics, and a little bit of sodium restriction may help with these patients. How do we treat SIADH? Well, SIADH is, again, it's a problem with ADH production, usually from a pituitary ADH release, or it's from an ectopic focus. So it is important to treat the underlying cause of SIADH. So if it's pain, treat their pain. If it's due to the particular drugs, minimize the exposure to those drugs. If it's due to COPD, pneumonia, treat those underlying diseases. If it's an intracranial disease, it's not something easy that you can actually fix. So in those scenarios where you're trying to reverse the underlying cause, you have to deal with the repercussions of SIADH. which is hyponatremia. And I want to treat the hyponatremia so that they don't develop seizures, so they don't develop cerebral edema and the downstream consequences related to high ICP. So what do I do? Well, the first thing is you have to ask yourself the question, is this something that the patient has had for more than 48 hours? And do they have no symptoms, no headache, no nausea, no vomiting, no vision changes, no encephalopathy, no seizures? If that's the case, I am not going to be aggressive with this patient. I'm not going to push their sodium up quickly. I'm going to go a little bit slow, and I'm going to be careful and cautious. So what we do is, in these particular scenarios, you do in a kind of an algorithmic like fashion. First thing is don't give them a lot of water. The reason why is any water that they get into their body and they get filtered across their kidneys, they will retain. The ADH will just be on the actual collecting duct saying, hey, give me all of that water. So I want to give them a free water restriction so that basically any of the water that they're taking in, if it is getting into them, I'm not going to be reabsorbing a lot of that water. And a lot of it will actually, again, not cause this hyponatremia. All right. If they're not responding to water restriction, and that's kind of tough, sometimes you have to limit them to like a liter, sometimes 1.5 liters of water per day. So in those particular scenarios where it's not working, you have to get rid of a lot of water from the kidneys. And so oftentimes we'll do this via loop diuretics. And so loop diuretics are very interesting because what they do is they act at the sodium-potassium 2-chloride cotransporter, so you won't reabsorb sodium here in the ascending limb, and therefore you won't draw water out going down in the descending limb. So water will stay in the actual tubules and be dumped into the urine. So if I lose a lot of water here into my urine, I'm therefore going to allow for my sodium to start kind of naturally rising up. Oftentimes we can give this in combination with salt tablets because that'll directly cause a rise in their sodium. If a patient has been on free water restriction, I put them on some loop diuretics, maybe even a little bit of salt tablets, and they're still not getting their sodium up, then only then will we consider something called Vaptans. These are pretty tough though. You got to be very careful because they can precipitate severe hypernatremia. What you're doing is basically you're trying to put them into a state of DI. And you're basically going to block the ADH. And so if you block the ADH, you're essentially not going to reabsorb water and you're going to dump a lot of water into the urine. And these patients can push their sodium up pretty quickly and they can actually develop some complications in this, such as osmotic demyelination syndrome. So you got to be very, very careful with giving Vaptans. Now, the other scenario of treating SIADH is if they're acute. So if they come in with a sodium that's relatively low and it's occurred in the first like 24, 48 hours, at least less than 48 hours, that one I might want to be a little bit more aggressive with. But the more particular trigger for me is if they are symptomatic. In other words, they come in with a headache, nausea, vomiting, confusion, seizing, high ICPs, and they look like they're going to herniate. In those scenarios, I will not wait and do this type of stuff and go slow. I'm going to push their sodium up as quickly as I possibly can. Another one is if the sodium is really low. So if they're symptomatic and if their sodium is less than 120, these are two really, really bad situations. These patients can be pretty sick and you don't want to wait and sit on your hands while their sodium is low and they're seizing and they're having ICP crises. So in this particular situation, you will give them 3% hypertonic saline. Oftentimes the guidelines say give them like 100 milliliters of 3% hypertonic saline. When you give them this, you're going to keep checking their BMPs to check their sodium like usually every 2 to 4 hours. Now, the point of this is that you've got to check it to make sure that their sodium over a 24-hour period does not exceed 6 to 8 milliequivalents in a 24-hour period. The reason why is, okay, I'm going to give them this to push their sodium up quickly. I want to push them up like 6 points, but then I don't want to push them up any higher. So if I get them from like 120 to 126, cool. I don't want to go above that in a 24-hour period. So I'd keep checking their sodium, and if they're going up above that, give them some water, right? Or, you could give them other medications like DDAVP, because you just don't want them to pass that 6 to 8 milliequivalent range. And the whole reason for that is that if you do pass that over a 24-hour period, there's literature to suggest that you can demyelinate some of the actual neurons in the pons and precipitate something called osmotic demyelination syndrome. These patients can actually present almost like in a locked-in state a couple weeks after they demyelinate. So maybe 2 weeks later, they'll develop things like dysarthria, dysphagia, diplopia, they'll develop quadriplegia, and they can even go into like a locked-in state. And that's a terrifying complication that you want to avoid. All right, we would be able to see this on an MRI of a patient. Maybe 2 weeks later, you can see all of this demyelination on their MRI here, on the T2, on their MRI here. You can see all of this kind of edema here, demyelination. This would be a concerning finding, especially if you overcorrected them too quickly. All right, my friends, that covers DI and SIADH. I hope it made sense. I hope that you guys enjoyed it, and as always, until next time.